Hey guys, um, this is like take number 474,962. I swear every time I sit down, it gets crazy at my house. The other day I was trying to get this recorded, and I found out that my cat goes into anaphylactic shock by getting stung by a bee. I didn't even know that was possible. So in the middle of my lecture, I had to stop and run to the vet and take care of her, and yeah, it's just welcome to my crazy life. All right, so I do want to get this. I actually had planned on having it up already. Um, but hopefully now it's midnight. There's only one person sleeping in my house. The rest are all up in their rooms and quiet, and my daughter's watching TV or watching my phone with the headphones on, so I think we're good. All right, so musculoskeletal system. The main point that I want you guys to take out of this, well, maybe I can get the slide up right. There we go. The main part that I want you to take out of this is the biggest concern with issues with the musculoskeletal system is safety. And these patients, their big manifestation is going to be in gait. Um, that's one of the major symptoms that they have. So anytime they have problems with their gait, they're a huge risk for falls. And so safety becomes the major concern. We want to make sure that they have a good quality of life, um, and that they're functioning to their fullest possible within their disease process, within their disease limits. Um, if you think of the musculoskeletal system, it's kind of like a framework. Like the skeletal system is the framework. The musculus holds up and moves the skeletal system. So just kind of think that it envelopes the whole body. All right, now I'm gonna try and I can never get the first slide to go. Haha, I did it today. Maybe it might actually run smoothly this time. All right, so um, an overview of the musculoskeletal system. There's different types of bones. There's long bones, short bones, flat bones, and irregular bones are the major categories of bones. So the long bones are generally the weight-bearing bones, like for example a femur. Um, Also in the long bones, at the ends of the long bones, uh, is where the red blood cells are made. There's red blood marrow in the ends of those long bones, and that's where the red blood cells are made. Short bones, um, they're small and they're non-weight bearing. So an example of a short bone would be like phalanges or the fingers. Flat bones, their major functions are to protect against all the organs, and there is a lot of this is where a lot of the blood cells are formed too. So example of that is the scapula. Not sure what vital organ, but that was the example the book gave us. I tried to kind of keep tie in with the book too, so which I finally did get the other day. Um, and then the other category is irregular bones. So irregular bones are basically unique shapes. Examples would probably be the bones of the inner ear. Where else do I want to go? Joints. Basically, what a joint is just two bones connecting. There's different types of those as well. The most common type is the synovial joint. There's a ball and socket joint and the hinge joint. Moving on to muscles, there's different types of those as well. One of these you'll get these all figured out, I promise, guys. The smooth muscle and the cardiac muscle are both involuntary muscles, which means they work on their own. They don't need the brain to tell them what to do. They just automatically do it. So smooth muscle is basically part of the autonomic nervous system. This is responsible for contractions of things in the organs, not the heart, and blood vessels. So maybe like the GI system. The other type of involuntary muscle is the cardiac muscle, which obviously is the heart muscle. And then the skeletal muscles are all voluntary. They need the brain to tell them to work. And obviously they do exactly what it sounds like. They move the body and all the parts. So now that you kind of know the different types, that'll help a little bit. we'll get into calcium and stuff in a little bit. All right, so bone tissue, bone cells. Osteocytes are just bone cells. The cells that make up the bones. The periosteum, that is just the covering. It's like a fibrous, tough, connective tissue that covers the bone, and it helps the tendons and the ligaments attach to the bone. Without this, they wouldn't be able to attach, and you wouldn't be able to move. The osteoblast and osteoclast. I want you guys to be able to keep these straight. The notes on this slide actually spell it out pretty good. So osteoblast, if you remember the B, this will help build. It repairs the bone. They almost sound like they should be flip-flopped, but if you remember that the osteoblast, the B, is for building bone, and osteoclast, the C, is for condemn. It removes the bone. So this is just a constant process. The old bone's removed, and the osteoblast produce new bone. Another kind of cleanup slide, aging in the musculoskeletal system. You guys have seen the elderly. You guys have worked with the elderly, at least even my group a little bit, groups. In the elderly, there's a drop in estrogen and a drop in testosterone. And when these hormones drop, the bone actually becomes weaker. They're not using it as much as they normally would. They're not walking, they're not working, they're not doing any of that. So the bone becomes weaker. The elderly have a decreased muscle mass and decreased strength also because they're not working, they're not moving, they're not doing the things that they used to. But the muscles also atrophy as they age. So, what? You guys will hear a term called osteopenia. Ari, the cat's stealing your strawberries. Sorry, I told you my house was crazy. Um, Osteopenia, that just means that it's just the fancy word for bone loss, or decreased bone density. Pam does have a note down here. Again, stressing safety in these folks. Whether they're at a nursing home or maybe they're going home, or at their hospital and they're going home, whatever the thing might be, or maybe they're in assisted living. Things to really make sure is happening so that we're decreasing their risk of falls. Tell them not to use the throw rugs. I know when I get old it's going to be terrible because I love my rugs. Remove cords so the cords aren't hanging out. Pam has a note here, colored strips on the steps. And another thing that I really like is the oxygen companies have gone to using green oxygen tubing. Oh my gosh. I apologize. But green oxygen tubing, so that way when the oxygen tubing is laying on the ground, people aren't, not seeing it. It's bright, dark, or it's dark green, but it's pretty bright, so it's contrast with the floor, which is a wonderful idea because elderly people have a habit of tripping over their oxygen tubing. Another note here, and you guys are doing this. I know you guys, I've seen it on everybody's NPW. I think every NPW that comes across my desk has this. Making sure we're having people dangle at the side of the bed when they're getting up. That has a lot more to do with their blood pressure and being dizzy and all that. But when they do suffer stuff with the musculoskeletal system, it is also a good idea anytime to have somebody sit at the edge of the bed, dangle for a minute, catch their bearings, and then get up. I do tell people, hey, you want to just sit there a second, catch your bearings before I bug you and get you up walking? All right. Okay. So going on to diagnostic tests. Calcium and phosphorus. They're two minerals that we see in the bones. They basically have, if one goes up, the other one goes down. Uh, it's an inverse relationship is how it's worded, but um, they never both elevate. And well, I shouldn't say never. It's healthcare, but usually they don't both elevate and both decrease. They wax and wane. One goes up, one goes down. Um, the calcium obviously is regulated by the thyroid, parathyroid, and protein in the blood. I'm trying to read my notes here. Calcitonin and the parathyroid hormone basically work together to keep the calcium levels and the phosphorus levels stable. So what happens is when the calcium level, if it decreases, the parathyroid hormone actually increases and stimulates the bone, the osteoclast, which is the ones that condemn, which are the ones that are breaking it down, to break down the bone. And when the bone is broken down, that calcium is released into the blood because I don't think I said it on one of the slides, but the bones are 99% of the calcium in our bodies is in the bones. So when the bones break down, the calcium is released into the bloodstream, and that's how we get our serum calcium levels. So when the parathyroid hormone stimulates the bone to be broken down and the calcium is released in the blood, the calcium will be floating around in the body, but when it goes to the kidneys, instead of being excreted, the parathyroid hormone helps it so that it is not excreted. It helps the body to hold on to it. Normal calcium is 8.5 to 10.2, and you guys know as well as I do that it kind of depends on the facility you're at. 8.5 to 10.2 is basically the ballpark figure. Just know that it might be 8.4 to 10.1, whatever the facility policy is. I want you guys to know the diagnostic or the levels because it is so very important for nurses to know. So start practicing early in your nursing school because it's something you will need to know. Phosphorus level normal is 2.4 to 4.1. Remember that these wax and wane. One goes up, the other goes down. All right. So we kind of talked about calcitonin and parathyroid hormone working together. Calcitonin actually decreases the calcium in the blood. It makes so that the bone inhibits the bone reabsorption, and it causes calcium to be excreted by the kidneys, and increased excretion of the calcium by the kidneys. Vitamin D helps the body absorb the calcium and the phosphorus from the small intestine. So if you have a little lady with osteoporosis, you will most likely see him on a calcium vitamin D pill. They're big horse pills and they hate them, but most little elderly lady are on calcium and vitamin D pills. All right, moving on to CK, the creatinine kinase MM. CKMM is the MM is the skeletal muscle. When a CKMM is run, they're looking for muscle disease or muscle damage. It will not tell you exactly what's going on. It will not tell you exactly where it's going on, but it will tell you that there is muscle disease or muscle damage. So examples of things that we would be looking at a CKMM for would be malignant hyperthermia. We talked about that in the perioperative, when we really just want to cool the person down because the muscles are breaking down because their temperatures are spiking, and rhabdomyolysis. I'm going to go off on my little spiel on rhabdo. So rhabdo, if you guys have ever heard of this, um, you see it more in like the elderly population. Not saying it doesn't happen in the younger, but I've seen it in my career. I've seen it more in the elderly population. So if you have a little old lady who lives by herself, she doesn't have a whole lot of family, maybe they're an hour away, so they don't check on her every day. She decides she wants to, I don't know, she wants to go get her mail. Well, as she's going downstairs to get out of the house, she falls down the stairs and lands at the bottom. Well, she left her cell phone up on the kitchen table because she was um, just going to be a minute. She doesn't have a life alert, and she doesn't have family checking on her. So she lays there for, we'll just say 24 hours. Could have been longer, but about 24 hours. From her fall, when she landed on the ground from the bottom of the stairs, and from laying on the floor, it's causing skeletal muscle damage. It's breaking down those muscles. Uh, it actually, the proteins are, we'll go through the whole thing, but the proteins are released from when the muscles break down and all those byproducts, and they start going, they're in the bloodstream, and so they have to be filtered through the kidneys. Well, they don't filter very well through the kidneys. They pretty much gum up the kidneys. So when this person uh, is found, they have to treat basically kidney failure as well. So symptoms of rhabdo, one of the biggest major symptoms is like a brown colored or a coke colored urine. It's because the kidneys are not filtering anything and because they're gummy, and we're going to give them lots and lots of fluids to flush those kidneys. Myoglobin is a test that will tell us about rhabdo, but that could be an myocardial infarction, an MI, or skeletal muscle. So it'll tell you that there's muscle damage, but it doesn't tell you exactly what's going on. It just gives us an idea. Um, alkaline phos, you'll see that with bone damage or liver damage. Um, normal is 42 to 136. So just know that with the CK, the creatine kinase you're looking for muscle disease or muscle damage. The alkaline phos is bone damage or liver damage, and a myoglobin is skeletal muscle or a heart attack. So basically cardiac muscle damage. All right, I think that's it for that slide. All right, so moving on to ESR. This is the erythrocyte sedimentation rate. They are called the ESR out in practice. Generally, this is about 0 to 20. When someone has like a flare-up that they're not diagnosed with arthritis yet, they might do an ESR, or to find something out where if there's inflammation in the body. When there's inflammation, that range, the 0 to 20, it's going to elevate. And if it's elevated, it's going to tell us that there's inflammation somewhere in the body, but it doesn't tell us where, it doesn't tell us exactly what's going on, but it does tell us there is some inflammation. We'll get into more with the ESR further in a couple other slides. The C-reactive protein, the normal is 0 to 5. This is another one that will elevate if there's inflammation, but doesn't tell you the whole story. The C-reactive protein is actually more accurate than the SED rate. The ESR, sorry, I'm used to calling it SED rate. It elevates quicker. Rheumatoid factor is either positive or negative. It's just looking for antibodies that are in the blood that attack the normal antibodies, if that makes any sense. I always have trouble explaining that. Um, if a person has a positive rheumatoid factor, they have developed abnormal antibodies that attack a person's regular antibodies. So it's an autoimmune, looking for an autoimmune disorder. The ANA, the anti-nuclear antibody, this one is just looking for things like lupus. You don't see it a whole lot, once in a while, um, but it is there for lupus. Myelogram, this is not a very common test. Basically, the person is a contrast dye is injected, and they look at the spine and the spinal cord. These people, it's basically this when a person cannot have a CT or an MRI is when they do this, but it's not very often. Anytime you give a person contrast dye, make sure you are assessing for allergies, and don't say, are you allergic to gallium or thallium? Ask them straight out, are you allergic to contrast dye? Have you ever had a reaction when you had an MRI or a CT with dye? Those reactions are pretty scary. MRIs, you guys know what those are. Um, can be used with or without dye. Again, as for allergies, don't just say gallium or thallium. The MRIs are generally done for like joints, soft tissue, maybe even bony tumors that involve a little bit of the soft tissue, whereas a CT is done, we'll look at when there's just bone injury. Arthrocentesis. This is, I saw my first one, I don't know, probably 2 years ago. It's actually pretty cool. Um, they inject a needle into a synovial joint and actually pull out the synovial fluid, and they can put pain medicine or steroids in there too. Um, but they're trying to get rid of some of the fluid, like fluid on the knee you hear, or maybe I've seen it done. When I saw it, it was done on the toe for gout, and you could literally see the crystals from gout in the synovial fluid. It was pretty crazy. Um, the gallium and thallium scan, not done a whole lot, but the gallium and thallium is the contrast dye. So what it does, it'll migrate to bone or brain, or breast tissue, uh, because tumors, especially like looking for tumors, because tumors like sugar, and that's basically what's in the gallium and thallium. And it kind of gives them like a hot spot. If you've seen, I don't want to say it's not night vision goggles, but like infrared goggles, I think maybe, or heat-seeking goggles. I don't know. Things on movies. That's kind of how the scan looks. Is it's like red, green, blue, depending on how much of the gallium thallium is sucked into like the tumor or that area. All right. Continuing on to diagnostic tests. Arthroscopy. Basically, the surgeon's going in and looking at the joint. He's not like cutting down, opening the whole knee. He's just inserting tools, cameras into areas and looking around. Um, After our patients have scopes done, we want to make sure we're watching for circulation, and we're going to teach them to ice and elevate and watch for infection where the tools were inserted. So I know there is the next one we go into some of the disorders, but I did want to just kind of review the assessment of the musculoskeletal system. So we can kind of do this when our patients walk in the room or as we're talking to them and they're, walking or doing something or while we're ambulating with them because, they need help because they have arthritis and they need a walker. So some of the things we're going to look at is posture. How is their body aligned? So maybe they have scoliosis and their back is twisted. Um, but we're going to really look and see what their posture is and how their body aligns, how the curves of the spine are, and if their extremities are the same length. So maybe they have more back issues. Maybe they kind of tilt to the right, so their right arm appears longer than their left arm. So we're just kind of looking at all this. Then we're going to kind of look at their muscle mass and see if it's, if we think it's decreased or if they're of strong build. Gait, again, like I said before, is the most common manifestation of problems with the musculoskeletal um, system. So we're going to make sure that look at their gait, whether it's shuffling, whether it's, you know, regular for them or a baseline for them. We're going to make sure that we're documenting that. And when you're looking at them, look at both sides of the body. Compare the right to the left. Whether there's, you're looking at size or swelling, if there's a deformity, or if there's poor alignment or pain or immobility. And then I know you guys we kind of went over this, and I am trying to catch up on some of my grading from last semester. I will tell you that. But things that I like you guys to monitor for on your head to toes is range of motion. And range of motion, is not just positive, yes, it's there, or negative, no, it's not. It's passive or active. So passive is if I have to move it for them. Active is if they can move it on their own. Say, hey, can you lift your arm up above your head? Whoop, I did it. So that is active. Can you lift your arm above your head? Nope. So if I hold her hand and pull it up, that is passive. And then you can also further describe it as full or partial. Can they do the full range of motion, or can they only make it maybe halfway? So you either document if it's full or partial. So then I wanted you guys to look at the muscle strength and tone scale. I know I've seen some people have used it, some people haven't seen it before. There is on page 1011 in IGGI, there is the actual muscle strength scale. But it's a scale of 0 to 5. So a 0 is basically there's no muscle contractions at all. It's just flaccid. Score of 1, there might be a slight contraction, maybe a slight twitch, but there's no movement. The person cannot move it at all. The score of 2 is the person can move it maybe a little bit, but once you add gravity into the equation, they can't move it. They can't push against the gravity. 3, there's movement possible against gravity, but they can't move it if you're trying to hold it down. You know, when the doc is doing an assessment or you're doing a neuro assessment, you can say, here, push against my hand. They can't push against resistance. A 4, movement's possible against gravity and some resistance. And then 5 obviously is full strength. So like a 1 would be about 10% strength, a 2 would be about 25, 3 would be about 50% strength of their baseline, a 4 would be about 75%, and obviously a 5 is 100%. So I hope that kind of brings it to, or explains that a little bit to you. I want you guys to use those just so you're more detailed in your head to toes. All right. So anyways, musculoskeletal and connective tissue disorders. When we're dealing with the musculoskeletal system, things to assess for are the 5 P's. It's pain, pallor, paralysis, paresthesia, and pulse. Sometimes it gets kind of hard to remember all those. So generally, I just have you guys do like CMS checks. circulation, movement, and sensation. That's generally what we use out on practice. Um, and we're still assessing for pain. Um, we're still assessing for mobility. Um, but it's a lot quicker, a lot easier. So for our CMS checks, we're always going to check for pulses, no matter if somebody had an injury or a surgery to their, I don't know, we'll say knee. We're going to check for pulses from the knee and below. We want to make sure that there's blood flow going all the way down. We're going to ask them if they can wiggle their toes. And we're going to ask them if they have any numbness or tingling. We'll get into more of these once we get into the surgical stuff. But anytime we are doing the assessment, I want you guys to really assess for pain, paralysis, mobility. But if you just remember the CMS check, that'll really help you remember what you need to do. Yeah, that's pretty much it on that one. I would much rather sit and talk about diseases. All right, here we go. Carpal tunnel syndrome. I wonder how many of you guys have had this. I had it. I had surgery on my hand. What it is that median nerve in the wrist, in the carpal tunnel, is compressed. There might be swelling, or when you are doing same repetitive movements, it's actually called a repetitive stress injury. The same repetitive movements is causing inflammation in that carpal tunnel. And when that carpal tunnel swells, it compresses that median nerve, which then causes the hand to be numb, tingly, painful, generally more often at night, and it becomes a problem when it starts waking our patients up at night. That's when they start doing things for them. They might be try putting them in splints, where they sleep in them, and then they may try splints during the day, different splints at night. They might be giving an anti-inflammatory. They can take ibuprofen or maybe even like a prednisone. And if none of that works, then they will go on to surgery and have that ligament in there released so that there's room for the swelling, the room for the median nerve, the swelling of the ligament is cut so that the nerve is no longer compressed because of the swelling. All right. Wow, I made it further this time, and it's a lot quicker. I think I made it to slide 6, and it was 25 minutes. A lot less windy in the middle of the night, I guess. All right. Fractures. Fracture is exactly what it sounds like. There is a break in a bone. And it can be caused from trauma or it can be caused from disease. Trauma is anything like a motor vehicle accident or a bike accident or a fall. Pathological from a disease, first thing that comes to mind is osteoporosis, which we will get into, but osteoporosis actually causes the bones to be really brittle and can actually cause the bones to break. So the different types are, well, there's a lot more than this, but what I want you guys to know is there's an open and a closed. So an open fracture actually punctures through the skin. The bone breaks and that jagged edge comes up and comes through the skin. So when we have an open fracture, that is basically just is the same as an open wound. The doc will go in there and depending on type of break and stuff, they'll fix it, but that patient's still going to have an open wound from when that bone came through the skin. So as with any time we have an open wound, we're always watching for an infection. We never want to just disregard it. Teach our patients the signs and symptoms of infection, what to watch for. And we'll get into osteomyelitis in a couple slides too, but because that bone was exposed, because generally it's an accident and things are dirty, whether it was a sports accident or a motor vehicle accident, the bone was exposed to bugs and dirt, we also run a risk for bone infection as well. Enclosed is exactly what it sounds like. The bone breaks, but it does not come through the skin. There's no break, so really there is a very, very minor risk for infection there. The fractures can be complete or incomplete. It can be all the way through the bone. It can be part way through the bone. It could be a stress fracture. Maybe somebody does a lot. What I think of is like track, where they're pounding on the track and running all the time. I've seen stress fractures like that. Or it can be compression fracture, where um, I've seen it a lot in the vertebrae in the elderly. There's no cartilage in there to soften when they walk or when they move, so the bones crush on top of each other, and it's compression fracture, and it's just as painful as any other kind of fracture. All right, these are pretty self-explanatory. Signs and symptoms. It really kind of depends on what the bone is that's broken. Um, there's going to be pain. They're going to be very painful. They're going to have a decreased range of motion, obviously, because the bone's broken. It's going to hurt. They can't move it. Um, the limb might be rotated, so or even shortened. So if a elderly person falls, you're in the nursing home and they fall, um, before they even get these guys up, they have to have an RN assess them. And one of the first things that you do is you look at their legs to see if one leg is longer than the other, or one leg is shorter than the other, or if that leg is tilted in or out when you compare it to the other one. Because when they break their hips, that leg will be shorter or longer, kind of depends on how the break goes, but it'll also twist. Deformity, some of the times you can see see exactly where the bone is broken. I think of gymnastics. I watched a nasty break one time when I was watching the Olympics, and they came off the horse and basically smashed their leg in two, and it showed them picking up their leg, and their bottom of their leg went one way, and it was terrible. There's going to be a lot of swelling, and there's going to be a lot of bruising. Fractures are diagnosed with an x-ray, and sometimes like a CT or an MRI might need to be done if it's a very tiny minor fracture. Um, Not to be taken any less serious, but it may just not be able to be seen on an x-ray, so it might be done a CT or an MRI. All right, emergency treatment of fractures. We come across a motor vehicle accident, and your person is clearly got a broken leg and they're having problems breathing. What's the first thing you're going to do? You're going to help them make sure that their neck and they're going to keep their airway open. Um, if they don't have an airway, or if they're bleeding out, or maybe like a concussion or something like that, you're going to take care of that first, because without an airway, without blood, the the broken bone means really nothing. So make sure you guys are prioritizing, but if your person does have a broken leg, make sure you're double checking them for any other issues, respiratory bleeding, and take care of that before you worry about the broken bone. So if you are, I don't know, stopping at a accident or working EMS, never try to reset that bone. Always splint it the way it is. Um, we play a little bit at VMH, and some of the splints they have are really actually pretty cool. Uh, we just splint it the way it is. The doctor is the one that will deal with um, going in and fixing it, straightening it. But right away, all we do is splint it the way it is. We're going to always be checking our CMS checks, a collar movement sensation, uh, distal to wherever the break is. So if it's in my humerus, we're going to be checking my fingers for CMS. So fracture, our end goal is we want that bone immobilized and we want the ends lined up. And I'm kind of looking at some of this stuff. Okay. More often than not, the docs are going to do a closed reduction. Is if it at all possible, they will try and do a closed reduction. They might have to pull and maneuver that bone so that it lines up. They'll be given a sedative. But rather than going in surgery and lining it up and having a surgical wound, they would much rather try and do it with a closed, not opening them up for surgery. I have seen a lot. Sometimes they will go back to like OR just because they are sedated, but the crazy things that I've seen in Viroqua Hospital, one of the old docs, Doc Men, he's at the neighborhood clinic now, but the patient came in from a motorcycle accident, had I think it was a broken femur, but he didn't have insurance, so Doc Men was trying to keep his bill down, so he did it right in the ER. Said it hurt like hell, but once the initial shock of the doctor pulling his leg wore off, it felt much better than before it was lined up. All right. Cass. Biggest thing I want you guys to know, never grab onto a wet cast or put it like right on a hard surface. So don't put it right on the examination table. Don't put it on a footstool. Make sure it's sitting on a pillow. And if you absolutely have to hold on to it, use the palms of your hands, not your fingertips. Because if you pick it up with your fingertips, you can actually cause indentations. And it can actually we'll get into the compartment syndrome in a minute. But it can cause compartment syndrome. And that's all because there's an indent on the cast. So, the cast that, when they put casts on, it's kind of a chemical reaction. They get it wet, um, and it'll start to heat up before it settles and cools. Usually takes like 10 to 15 minutes to dry. I mean, it won't be like, super dry, but it will be very, very well on its way. So basically 10 to 15 minutes is a good time to just let the patient sit, let the cast set, um, and then move it, or if they need to get up and walk or however. Edges need to be smooth on the cast. A lot of times they'll take that batting and fold it over and then put the fiberglass casting or plaster casting. Um, Anytime a extremity, whether it's a leg or an arm, hand, whatever, is in a cast, we need to teach our patients that they need to elevate it for 24 to 48 hours. Ice is extremely important, but you can put ice on a cast and they will not feel it. So if the cast is on the foot, you want to put ice behind the knee. That is where the blood vessels are the closest to the surface. And by putting the ice where the blood vessels the blood is passing by, it'll actually cool the blood down and it'll cool underneath the cast. rather than trying to figure out some crazy way to get the coolness into the cast, just cool the blood behind the knee and it'll cool all the way down to the foot. If we're helping put a cast on, we need to assess that it's dry. We need to see how tight it is, because they should be tight and they should not have any real movement in there, but it can't be too tight because anytime somebody is in a cast, there's going to be swelling in there. We're going to watch for any drainage, any odors. Obviously, we're going to do CMS checks. I cannot stress that enough. CMS checks, CMS checks, CMS checks. Anytime there's surgery, broken bones, traction, CMS checks, just to make sure that they are having circulation all the way through. Anytime there's a surgical procedure done on the distal end, you need to make sure you're double checking and making sure there's CMS. All right, anyways, back to casts. And we're going to monitor their skin around their cast. Make sure it's not breaking down because casts can be pretty nasty. And you always get that one patient that's stuck crazy things down in the cast to itch it. Yeah, no. That's another thing we need to teach them is do not do that. Not only will it get stuck in there, it'll cause an open wound, and then you got infection, and it can just lead to all sorts of terrible things. These are just the different types of casts, just depending on where the break is. All right, I've got to take a break and get something to drink, so I'm just going to pause this for a minute here. All right, guys, I'm back. All right. Like I said, these are just the different types of casts. All right, moving on. Traction. Traction is used, most common that I've seen it used is when a person has like a hip, like our femur fracture. What it is kind of like this picture here. But the person gets a foam boot placed on the leg that has the broken femur. And attached to the boot is a pulley system and some weights. The boot is weighed down over the edge of the bed so that it pulls that femur so that it's not butting up against. Like the broken ends aren't meshing and grinding against each other. First time I saw traction applied that I was responsible to monitor was an 82-year-old woman who fell off the bar stool. Sweet as pie. She only went to the bar to go have one soda and to socialize. This was a long time ago. But she miscalculated the bar stool and fell off. She wasn't drunk. She was just a silly little old lady. But the amount of pain that was reduced when the traction was in correct alignment was amazing. She was just writhing in pain, and once we got the traction set up, she was able to hold a conversation with us. It was really, really impressive. The traction really helps with like muscle spasms because all the nerves are damaged in there and the muscles are damaged in there. When those bones grate against each other, it causes the muscles to spasm and the nerves are haywire. So it really helps with the muscle spasms. So how do we do traction? We have a person in bed and they are as straight as possible, as straight can be. It may be a little uncomfortable getting into the position, but believe me, they will thank you for it later. So we stand at the edge of the bed and look up at them and make sure that we are looking straight, that they are straight aligned from their toes to their head. We want them in a straight line. If they are not straight, like maybe they're kind of the upper part of their body's off to the right, we need to make sure we're teaching them, come back here, you need to be straight up and down. So the alignment is our number one priority. If they're complaining of increased pain, like I said, the first thing we check is their alignment. And then we're going to check the weights, the ropes, the pulley, make sure they're all in correct working order. And we need to make sure, I think, I don't remember what the rule of thumb is, but I know Broca's protocol is to monitor circulation CMS checks every hour at least. So it's another time that I'm going to preach and preach and preach CMS checks. So takeaway from traction, our job may be setting it up. It's not like we're resetting the bone like a doctor would. We are just pulling that so that the ends of the bone are not crushing and mangling towards each other. We are very capable as nurses to set up traction. We can and we will be doing it. And we need to make sure that they're aligned straight up from the head to the toes or toes to the head, however you want to do it. But stand at the bottom of the bed, look up, and make sure they're straight. Because if they're any kittywampus at all, they're going to have increased pain, increased spasms. All right. We're kind of moving along. Kind of windy tonight, but an ORIF, open reduction internal fixation. So what that is somebody has a broken bone. The doctor goes in, does this, surgical, so he can actually look at the bone, and then he's going to fix it with screws, plates, whatever they may need. Sometimes they're going to need to have the hardware removed. Sometimes they'll just leave it in. It just kind of depends on what the break is, how the healing is. So sometimes they'll take it out, sometimes they won't. Again, huge assessment for an ORIF is CMS checks. All right, external fixation. This is exactly what it looks like. It really looks like a medieval torture device. First time I saw one, I was doing home health, and it was on a 16-year-old boy. And I walked in and I was like, oh my God, what did I just get myself into? The external fixation is when there's multiple fractures or that bone's crushed or there's no way to really go in and fix it internally. The bone needs to be held in place from the outside. So you can see the surgical pins are going through the skin into the bone. And then they keep this frame on, and it keeps the foot elevated and keeps it where it needs to be. It keeps it still so they're not moving it around. But they are very, very heavy, and they're really hard to work with. A major risk factor for external fixation is infection. Because basically that pin is going from the skin into the bone. And that leaves a little area around the pin that bugs can crawl in and go settle in the bone, go settle in the tissues, go settle in the skin, and cause an infection. So every shift or every day, whatever, depends on what setting you're in, monitor for infection. Teach family members how to monitor for infection as well. I think that's pretty much it. I would have a story about my soccer kid. I'll tell you the soccer kid story once I get to compartment syndrome. All right. Moving on. Complications of fractures. A little bit more than what's on here. The bones are very, very vascular. So there is a lot of blood flow through them. So when there is a bone fracture, they can actually hemorrhage into the tissues. And if they're hemorrhaging into the tissues, they are at a huge risk for hypovolemic shock. Infection is always a huge risk in fractures. Um, Thromboembolic. This is probably the most common um, complication of a fracture, or even like a lower extremity surgery, is the DVTs and a PE, because these people aren't mobile. So the blood is just pooling and then it starts moving around. Um, I'm going to skip the acute compartment syndrome because we got a couple slides on that. Fat embolism syndrome. Actually, there's little fat globules that get released from the bone marrow, the yellow bone marrow, into the bloodstream, and they start clogging blood vessels. And generally, fat embolisms travel to the lungs. I'm not exactly sure the pathophys behind it, um, but the fat embolism usually goes to the lungs. You're going to see them. The patients are going to be hypoxic. They're going to have trouble breathing. They're going to be shallow, fast breathing. And with fat embolism syndrome, these patients are going to have like petechiae rash across their chest. I also do coroner work, and I've seen it where they've thrown a blood clot, thrown a PE, and it's really weird. From the nipple line and up, they were like a deep red purple, and the nipple line and down, they were white. Once you see it for the first time, you will never forget it. So it's just like this petechiae rash from the nipple line up. Another risk is non-union. If there's a fracture and it's not healed within 6 months, that's considered non-union because it should be healed within those 6 months. What else are we gonna see? Fractures, complications. Crush syndrome. We go back to the rhabdomyolysis. You might see shock or even kidney failure because these patients are experiencing crush syndrome. And then another one that's not listed here either is complex regional pain syndrome, CRPS. I think it's a lot more common than we really know about it. I've been hearing a lot more about it lately. But anyways, it's pain that's lasting more than 6 months. Because it's caused by like damage to the peripheral and the central nervous systems. Symptoms we'll see, skin texture is actually changed in the area that it's affected. Patients actually have an abnormal sweating pattern, like they'll either sweat more or sweat less in that area. Nails and hair growth will be changed. It will be different. They might be stiff in that area, like a stiff shoulder, stiff ankle, whatever. We're gonna see poor coordination, like they're not able to move it like they had been before the break. And then we might also see things like dystonia, where they are kind of frozen, or where they might be having tremors and shaking or even jerking. So CRPS is a little bit more common, learning a little bit more about it. All right, next slide. This is acute compartment syndrome. All right, I don't want to get into too much because I have it all written down on the next couple slides. But you can see here, maybe this person, my guess would be they had been in a cast on their wrist, kind of like a broken arm cast where it goes up around their thumb and around their hand. So once a person has acute compartment syndrome like this is how they treat it. Very, very scary. This is the 16-year-old boy that I was talking about that had the external fixation device on. Also got acute compartment syndrome. He was playing soccer, and one of the other team members tried to steal the ball from him and kicked him right in the shin. Shattered basically his shin. So That's why they had the external fixation, is because it was broken in too many places to put it all back together. It was basically a crush injury, which also leads to acute compartment syndrome. But when he had all that, it ended up going to have, he ended up having acute compartment syndrome. So not only did he have the external fixation device on, he also had these triangles, ovals, football shapes, triangles, whatever. The football shapes cut out of each side of his leg, just because there was no room for the swelling to go. So let's actually get talking about acute compartment syndrome. I feel like there's a bunch of hype in it in the slides in the beginning. All right, so what it is there's compartments in the body, where they're covered by fascia, but there's muscles, blood vessels, and nerves in this area covered by fascia, and that's a compartment. When these compartments are swollen, um, maybe blood flow is, or maybe they're bleeding into it. Maybe the plasma proteins are leaking into the interstitial space, you name it. But when these compartments are, for some reason, swelling, edematous, there's no place for the swelling to go. There's no place for the fluid to go. So it builds up in this little bag of fascia, if you will, and it cuts off circulation. The muscle tissue, because there's no way to get blood in there, the muscle tissue actually becomes ischemic. Some of the causes, if a person has a cast on or an ACE wrap and it's too tight, they might have compartment syndrome. If you've ever had a cast, say you broke your arm, generally they put a soft cast on for a couple days and then you come back and you put a hard cast on. Well, this is the exact reason, because the swelling is too much, and it's going to be too much for the first couple days, that they want to have something on that can move. So they put on the soft cast. Once the swelling is gone, starting to come down, then they put the hard cast on. So if you have a patient that you are working with, and I don't know, I'll use myself for an example, although I didn't spend the night in the hospital. Anyways, you have a patient that comes back from surgery, had surgery on both feet. They started complaining of pain in their right lower leg. You give them, I don't know, I think they have Dilaudid ordered. We'll just go for the big guns, I guess. They have Dilaudid ordered. You give it. It doesn't even knock down their pain at all. This is just a big, huge idea to us that might be compartment syndrome. So we're going to keep checking our CMS checks, and we're going to keep watching their pain. If they are not responding to our pain meds, we need to make sure we're looking to see if that cast is too tight. So, what else do I need to tell you on this one? Again, it's the 5 Ps, or the CMS checks. With acute compartment syndrome, generally the pulse will not just completely disappear. It'll just become very weak and very thready. So, all right. Goodness. I showed you that picture. This one. That's a fasciotomy. It looks like a very nasty fasciotomy, but that's a fasciotomy. Just so that the fluid and the swelling can be relieved. Getting ahead of myself. So treatment, we're going to cut that cast. um, or we're gonna give them a fasciotomy. So that picture with the football shapes carved out of the legs, that is honestly what they do. They cut the skin and then they cut the fascia, so that muscle and the nerves and that can all expand with the swelling or the blood or whatever have you that's in that compartment. Um, it expands, and so when you cut open that fascia, it gives it room to go. And the person will stay with those open wounds like that, those open football shaped wounds, until they get better. Um, the kid that I had that had it, we actually were doing wound vac dressing changes with lidocaine, um, and then oh my gosh, name of it just flew out of my brain. 1:30 in the morning, of course, everything flies out of my brain. Um, it's a yellow petroleum. Anyways, a type of petroleum impregnated gauze had to be over any part that we didn't decide to put a wound vac on, or the pin sites, just to make sure that there wasn't any infection. It was pretty scary. Um, all right, we kind of went over this already. I don't remember why we went over it, but we did. Fat embolism, just to review, the fat globules released from the yellow bone marrow into the bloodstream, and they cause respiratory distress. Patients who have multiple fractures or long bone fractures are at higher risk, and patients with any fractures are at risk for basically 72 hours after the fracture. Um, Symptoms, change in mental status from a decreased oxygen level. Anytime you have somebody in respiratory distress and their oxygen level is low, they're going to be confused and uncooperative most likely. But these patients are going to have, they're going to be tachycardic, tachypneic. Their blood pressure is going to elevate, and they're going to have that petechiae rash from the chest, um, upper arm, basically nipples and on up. What are we going to do about it? We're going to give them O2. We're going to raise their head of their bed so they don't have to work to breathe at all. We're going to call a rapid response team and the doctor. Going to keep them in bed. Going to get the x-ray up there to do an x-ray. ABGs to make sure we're perfusing. And then any IV fluids or meds. All right. Osteomyelitis. Sorry, I had to get a drink. All right. Osteomyelitis. This is an infection in the bone caused by bacteria. That infection can actually cause decreased blood flow, so that bone can actually become necrotic. It can be chronic or it can be an acute. Depending on, I've seen chronic osteomyelitis in a diabetic foot ulcer. I've seen chronic ones in just, terrible feet care. And I've seen acute that almost took out a young man. So, staph infection. Um, Staph is actually one of the bigger things that cause the osteomyelitis. Um, and another risk when we're talking bone infection is MRSA. Because if it's chronic, it's a huge risk of it being MRSA in there, especially if they've had a wound for 2 to 3 years. Prevention is key. Absolutely. If we have a patient with a foot ulcer, diabetic foot ulcer, or wounds because of PVD, we need to make sure we're keeping those wounds clean and monitoring very closely for an infection. Because a lot of times you'll see an infection on the outside before you see it travel to the inside. Um, for osteomyelitis, the symptoms we're going to see, these people are going to run fevers. Um, the area of entry, I should call it. We're going to see redness around that. We're going to see heat there. They're going to be complaining of pain. It's very painful. There's going to be swelling in the skin. Um, temperatures are probably going to be greater than 101. And I can't stress enough pain. So it is all the common signs of infection, but it's just taking it. It generally starts as maybe a skin infection and it travels into the bone. Sometimes people are going to need to be on long-term antibiotic therapy. Generally, it's about 4 to 6 weeks, and depending on what the cause is or how they got the infection, sometimes they might need like antibiotic beads placed. So if I've seen antibiotic beads done when people have had like a hip done or a knee done and have gotten infection in the bone that way, or even infection in the new appliance or bugs settling on there. They take the new appliance out and they put antibiotic beads in for 6 weeks, and they go in and put the new appliance in there. CNS checks are going to be done, and they are done with a swab, trying to get some of the gunk out, send it into the lab to determine what antibiotic is going to work, and what type of bug it is. What else? What else? Osteomyelitis is very serious. It can actually lead to, like, somebody could lose their mobility. Somebody, I've seen amputations. I had a lady, who had a mix of osteomyelitis and peripheral vascular disease, and her toe fell off in my hand. You hear people talk about it, but it honestly happened, and it just happened to be my cousin's family member, cousin's wife's family member. So I had to call her son and be like, yeah, I have her toe in my hand. But because of osteomyelitis and the PVD, it basically ate away at the foot, and there was no circulation, and it just fell off when I took her sock off. Osteomyelitis can actually lead to death as well, just because sometimes these people can go septic, and because treating these are so hard. It takes a long time to get rid of a bone infection. Part of the scary thing is that people with osteomyelitis may not have the huge increase in pain, because if that infection has attacked the bone so bad, it may have actually damaged the nerves. So if they aren't feeling pain, it's kind of scary. I had a young man who he had cerebral palsy, and he hadn't walked in a very long time. I don't remember how many years it had been. But he used a slide board, was in a wheelchair. Kind of a pain in my butt. I still talk to his family. I haven't seen him for a while, but I see his dad out and about. I was at work on a Friday and had been looking at wounds and found that he had a very light red spot on his coccyx. Mind you, he's already got a catheter, or a suprapubic catheter, and a colonoscopy. It's in the middle of the night. Colostomy bag, not a the colostomy bag, because he is healing from a wound on his coccyx. So I saw this little pink area. Um, no, it was on his hip. Sorry. Um, little pink area on his hip on Friday. I come back on Tuesday because Monday, I think it was Memorial Day weekend. Um, I come back on Tuesday and look at it, and in that short time, I'm sure it was brewing underneath before it showed up. Um, the drainage had become green. I sent him in, and he literally had osteomyelitis so bad that it had dislocated his hip, and that's why um, he ended up getting a total hip replacement. Um, he needed therapy because he couldn't move like he used to, because the bugs had basically eaten away at his joint, his hip joint, and he was on antibiotics for, I want to say, I think it was like 12 weeks. It was terrible. Um, but just to show you that it is very serious. I remember the day his brother came to visit him. I'd never met his brother before, and him and his dad came down to my office, and I got up because I mean they were a Southern family, and his brother picked me up and swung me around and said, "Thank you so much for saving my brother's life." And it's scary because it can just turn that quick. That was a matter of 3 days. So just very keep your eye out because it can happen quickly. Um, yeah, sometimes these patients with osteomyelitis, they can't take care of it at home, so they might actually be admitted to a nursing home for antibiotics, for dressing changes, you name it. Um, that kid that I was just talking about was actually in a rehab facility for 2.5 months because of it. All right, osteoporosis. With osteoporosis, the bone mass decreases and the actual structure of the bone deteriorates. So if you look at these pictures down in the corner, you can see how the normal bone looks kind of thick. The bone with osteoporosis just looks like a sea sponge. Um, it almost looks like you could just crush it. If it was dry enough, you would just crush it. Um, so the bones become brittle, um, and they're very, very easy to fracture. I've seen several times in my career where we weren't sure what happened first, the fracture or the fall. Uh, so a person was standing there and they wouldn't even have to be moving depending on how brittle their bones were, and literally their hip would break and they would fall. Not they would fall and break a hip, they would break a hip and fall. Um, there is a genetic component, an environmental and lifestyle component. Um, thin postmenopausal women are more common to have osteoporosis than anyone else. Uh, Thin only because larger women or obese women can actually store estrogen in their fat tissues, and that helps with the osteoporosis. Um, yeah, because once their estrogen levels decrease after menopause, that's what causes the changes in the bones. I think we kind of talked about that earlier. Signs and symptoms. You're going to see the Dowager's hump or kyphosis. I think that's on this page right there. That's the Dowager's hump. Um, their height's going to decrease. You always hear people say, "Oh yeah, I'm getting older, I'm shrinking." Um, they're going to complain of back pain. They might complain of fractures, or they might have fractures. Obviously, they're going to have fractures. Sorry. Um, just because that bone is so brittle. How are we going to treat it? Meds. We're going to look at risk factors and see what we can't decrease: smoking, is a huge risk factor. There's alcohol, um, sedentary lifestyle, all the same ones for diabetes. But we're going to try and get them to increase their calcium, whether they got to do calcium and vitamin D. Um, really going to try and keep them safe and making sure they're not falls. That's a big one. But some of the meds they might take are um, vitamin D and calcium. Fosamax, if you guys have ever heard that, that is one that they take once a week. And they have to take it and remain upright for 30 minutes after taking it. Actonel and Avista, I'm not as familiar with. They might be on calcitonin. Um, Estrogen would help because once somebody goes through menopause, like I said, their estrogen levels drop, and then that sends osteoporosis out the window, gets it flared up. Um, but there's too many side effects with estrogen, like breast cancer and heart attacks. So even though estrogen would help with osteoporosis, the risks outweigh the benefits. So um, that Fosamax that I was talking about, the once a week, it just basically slows down the bone reabsorption. Um, there is a newer one out, this Prolia, and I can't say Denosumab is the generic name. But this is only when other meds aren't working and the patient is having severe symptoms. And it's on the injection every 6 months. All right, so tests for osteoporosis: CT, ultrasound, a DEXA scan. Um, a lot of times women are encouraged to get a DEXA scan for a baseline at age 40. And then if they're on meds for osteoporosis, they'll do another DEXA scan every 3 years. Just checking how many slides we have. Oh, we got 20 left ish. All right, Paget's disease. I have never worked with Paget's disease, I don't think, not that I remember. Um, but Paget's is a problem in the bone remodeling process. It's abnormal. So new bone is made in incorrect locations, and bone is removed from unintended areas. So they're making bones and taking bones away from not where they should be making bones and taking bones away from. There generally aren't any symptoms. One of the first symptoms, only symptoms, is bone pain, which is not very common. Um, you can see where the iliac crests here are kind of disappeared because of Paget's disease. Um, anytime these people have a fracture, it's going to take a very long time to heal because the bone renewal process is so messed up that it's taking good bone away, and so. All right, I'm going to take a break and get another something or another to drink. Hello, I am back. It is now 2 o'clock, and my 8-year-old just sat up and looked at me and said, "Yeah, I'm still awake, Mom." Oh, okay. Um, I don't know how many of you are having the issues with your kids not sleeping now that they don't go to school. Mine never sleeps, I swear. All right, on to strains and sprains. So a strain is a stretching or tearing of a muscle or a tendon. Generally, this is caused by overuse. You know, maybe somebody's been out doing yard work all day long, working too hard, shoveling, you name it. They might have a muscle strain. A sprain is a stretching or tearing of a ligament. Generally, you'll see this more with like sports injuries, falls, motor vehicle accidents, where there's an actual injury. With a sprain, you're going to see more edema, more pain, um, and the joints are not going to be mobile. They're not going to be able to move their joint, whether it's their ankle, their knee, their elbow even. Both of these are treated with RICE: rest, ice, compression, and elevation. Might be just an ACE wrap or, like an elastic brace. And then elevation is we need to teach them to make sure that they're elevating it above the level of their heart. That'll help with the swelling. If they have a strain or a sprain, we're going to treat them with this rice for 48 hours. If they do not see any improvement, they're going to have it reevaluated, make sure there isn't a fracture or something in there. You need to reassess it. Elliot, quit. All right. Moving on. We get to talk about gout. Um, so gout is a connective tissue disorder. What happens is the uric acid builds up in the blood and then it hangs out in the joint. Generally, it happens in the big toe. Those crystals get deposited in that joint and they can't move their toe. They can't. It's red. It's hot. It's swollen. It can happen in other parts of the body. I've seen it in the hands, but the most common area is the big toe. This is I saw where they aspirated the um, the synovial fluid from it, and it was just full of crystals. That poor woman was having so much pain, and it was just because all these crystals, they're sharp, um, were built up in her joint. Two different types. There's primary and there's secondary. Primary is it's just the problem because they can't metabolize the purines. Secondary, it's caused by another health issue. All right. Signs and symptoms, we went over that. The joint's going to be swollen, red, hot, painful. Um, Here's a picture of gout in the hands. You can see the deformity, and that's just the uric acid crystals built up in those joints. It's awful. Chronic gout is rare. Um, it happens, but not as often as acute gout. Um, for diagnostics, they're going to draw a uric acid level to see how much uric acid is actually circulating in the bloodstream, and then pulling out that joint fluid, looking for those crystals. Treatment is different meds. Colchicine is more used for an acute exacerbation of gout. NSAIDs are going to be given to help with the inflammation. And allopurinol is given for people who have frequent exacerbations of their gout. So basically, it just decreases the uric acid production so that they're not having so many flare-ups. And this is allopurinol. The Benamid or the probenecid will help those kidneys get rid of the uric acid. We also want to teach our patients with gout what foods to avoid. Purines are in things like wild game, red meat. Some seafood has it. Organ meats have a lot of purines in them. High fat foods have it. Beer and whiskey are actually very bad for people with gout. And like smoked meats or summer sausage. I really kind of, when I think of gout, and I know this is kind of stereotypical, but I think of the old bachelor who drinks a lot of beer. That's how we remember what gout is and what diet we don't want them to eat. So, um, we want to avoid aspirin and diuretics. If we give them diuretics, they're going to be urinating and have a risk of being dehydrated. And the more concentrated the blood becomes, the more uric acid is in the blood. So if we take out all the extra fluid, the blood's going to be thicker, there's going to be more uric acid, and it's going to end up settling in a joint. We want to have them increase their fluids because we don't want to give them diuretics because they might get dehydrated. We want to make sure that they're taking in more fluids so that those uric acids don't settle in the kidneys and cause kidney damage. skip a couple of my slides. Oh, I'm starting to get tired. I apologize, guys. All right. Muscular dystrophy. Um, this is just where those skeletal muscles are degenerative and they're seeing a lot of atrophy. There's muscle tissue loss and muscle weakness, obviously, because the muscle tissue is being lost. Medical treatment for muscular dystrophy is basically supportive care, trying to prevent complications, whether if they're immobile, like pneumonia. We want to make sure they're not getting pneumonia. Um, yeah, it's an inherited. It's genetic. Oh, that's all there is on muscular dystrophy. There isn't a whole lot. I think I need some more coffee, guys. All right, osteoarthritis. Osteoarthritis is also called DJD or degenerative joint disease. Osteoarthritis is very common. Um, Please remember that osteoarthritis does not have to be in both sides of the body. You can have osteoarthritis in your right knee and not have it in your left. So, what it is the um, cartilage on the ends of the bone get worn away and bone spurs developed and then bone rubs on bone. It's a wear and tear disorder. Um, the joint becomes inflamed. Um, Most common are the weight bearing joints, so the hips, the knees, the hands, and the vertebrae. Causes, um, I don't really understand what this means by causes unknown, um, but it's basically caused when, like, people are obese or elderly, um, or people who do a lot of manual labor for their job. It's a wear and tear on those joints that causes them to break down. So what are we going to see? We're going to see joint pain. We're going to see stiffness, but both of those are going to get worse after someone has been physically active. Um, when we get to rheumatoid arthritis, I'll tell you the difference. But for osteoarthritis or DJD, it's people are active and the pain gets worse. This picture here, we're going to see Heberden's nodes and Bouchard's nodes. It's just the different locations of those bony nodules. You can see the picture with the skin on it. You can see where the nodules are in the bones. All right, tests for osteoarthritis. We're going to see x-rays, CTs, MRIs, and we're going to have them look at the synovial fluid in the joint. They might have some of the fluid or pulled out and looked at. Another thing that's going to tell us if they have osteoarthritis or basically inflammation is the ESR or the SED rate, because that tells us that there's inflammation. But they do ESRs for osteoarthritis. Basically, there's no cure. They can take meds. They can take NSAIDs like ibuprofen. We can encourage them rest and exercise, hot or cold. We can teach them some lifestyle modifications like losing weight, because the less weight they have to carry around, the less um, the less it affects their joints. We can always use imagery, music therapy, acupressure, acupuncture, those types of things to help with osteoarthritis. And then as a last resort, um, they'll have surgery, a total joint replacement. We'll get into that in a little bit. Um, Patient education. What do we need to teach them? Well, this might be new to them. So we're going to need to teach them all of this stuff. We're going to need to teach them how to protect their joints. We're going to need to teach them to keep their weight at a lower number, just because of how much it affects them. So basically, overall, these patients have a knowledge deficit, and we need to teach them everything to help them through the osteoarthritis because there is no cure. Rheumatoid arthritis. This is an autoimmune, a chronic, progressive, systemic inflammatory disease. Um, it begins by destroying the synovial joints and the connective tissues like the cartilage and all of that in the joints, but it can also affect the major organs. Um, People with rheumatoid arthritis actually get what's called synovitis, where that synovium, the fluid, thickens, and more fluid accumulates, the joint gets swollen. Um, there becomes a new synovial fluid in there that has all these inflammatory cells in there, and it can destroy all the cartilage. So when this pannus, this newer synovial fluid with all the inflammatory cells, um, gets in there, it can actually um, change or form into actually bony tissue, and that's what causes some of the deformities. Um, like I said before, it's in an autoimmune disease. It's basically the body's attacking itself. Um, the the body has antibodies that are attacking the body's antibodies. So um, just know that this is basically a result of the body attacking itself and or an autoimmune response. Um, Osteoarthritis can be one-sided, so you don't have to have both knees affected. But rheumatoid arthritis actually affects both sides. Um, it's bilateral, it's symmetrical, um, and that's the big difference between rheumatoid arthritis and osteoarthritis. Um, with rheumatoid arthritis, these guys are going to have remissions and exacerbations. Some days they're going to be doing great, and sometimes they're going to be doing terrible. So early symptoms that we're going to see with these guys: bilateral symmetrical joint inflammation. So if a person is having problems with their thumb joints on the left hand, they're more than likely going to have problems with the thumb joints on their right hand. So these joints are going to be red, warm, swollen, stiff, painful. Um, Another thing that sets it apart from osteoarthritis is these people, once they rest, they're going to be stiff. Once they get up and start moving around, that pain and that stiffness is going to go away. So osteoarthritis is pain after they've been active, and rheumatoid arthritis is pain after they've been resting. In the later stages of rheumatoid arthritis, it actually affects the organ systems, and it can really do a number on pretty much any system in the body. How we're going to diagnose it? I can't talk. The rheumatoid factor that I talked about, it's either positive or negative. Red blood cells, the C4 complement decreased, the SED rate or the ESR is going to be elevated. The anti-nuclear antibody test is going to be done, and that's going to be positive. C-reactive protein is going to be positive. It's just because the body is basically attacking itself. So all of these labs are going to come back positive because of the inflammation. Treatments are going to be basically, a lot of times they're going to be on prednisone. If they're not on it long term, they might be on it for their exacerbations because their immune system is. What happens is the immune system becomes overactive, and the immune system is already attacking itself. So when they take prednisone, it actually knocks the immune system out so that it no longer attacks itself, gives them a little bit of relief, and that's why they're on prednisone. Methotrexate is also a big one used for rheumatoid arthritis. It's also a chemotherapeutic agent, so you can imagine the side effects on that. These people need to learn how to balance their rest and activity. They can't rest all the time, otherwise they feel terrible. But they can't go all the time either, because fatigue is another symptom of rheumatoid arthritis. And eventually they may need surgery, whether it's a hip, a knee, a shoulder, um, and just get their joints a totally new joint. What are we gonna teach them? Oh, we're gonna teach them not to stay up till 2 o'clock in the morning. Anyways, we're gonna teach them about their disease processes. We're gonna teach them about their medication, because people who are on methotrexate, a lot of time, if their provider doesn't sit down and talk with them about the side effects of it, they may not know. Um, Methotrexate is very hard on the eyes. So when our patients are on methotrexate, we need to make sure that they are having their eyes examined frequently, like every 6 months instead of every year. They need to be examined every 6 months. We're going to teach them about rest and exercise. We might need a counselor to help them with vocational stuff, and then community resources. You guys know this stuff. Musculoskeletal surgery. I actually had the pleasure when I worked at the hospital before I did home care. I actually worked ortho quite a bit with Dr. Lawrence. You guys, I don't know if you guys have ever heard of him, but he is a amazing man. He knows his stuff. He has developed protocols and developed his own surgical procedure and you name it. And he has one of the lowest infection rates in the country, actually. Um, but I got to work with him for several years and I learned a lot. So, anyways, total hip replacement. So you can see the picture down at the bottom. They basically drill a hole into the femur and insert this. Basically, it's the same thing as the femur, the ball, and into the neck on the femur. And then in the hip joint, the hip socket, they actually have like a little cup. So that metal ball fits right into that metal cup. And that's how they do the total hip replacement. Let's go to our next pages. Is that on the page? Oh, no. Before they have surgery, there is a big education sessions that they need to go through. It's a couple sessions, but they are taught everything, and this is without meds. So you're not coming into surgery and trying to learn your aftercare, but they have to have everything set up, everything. They have to show Dr. Lawrence that, hey, yeah, this is what I have planned. This is my work stuff. Or if they're retired, they have to have this is who's staying with me, or this is my plan to go to a nursing home. It all has to be set up before they even come that day for surgery. Um, it has here an autologous blood donation. I don't know how much they actually do it where they give blood like before, a couple days before surgery or whatever the deal is. And I know Broqua doesn't do it anymore either, but we used to have a machine that actually drained out the extra blood that was sitting in that joint, and we cleaned it up and we gave it right back to them like we were giving a regular blood transfusion, but it was their blood. We just recycled it and cleaned it up. All right, so post-operative care. Um, we need to monitor for internal bleeding. Generally, hip replacements do not have a lot of blood loss, but they might be hiding some in there. We need to watch for neurovascular issues. Again, CMS checks, CMS checks, CMS checks. Please monitor for your color, your movement, your sensation, your pulses. Make sure they have a pulse. If they had a hip done, we want their pulse all the way down in their foot. Um, Pain is a big thing. If their pain's not controlled, um, they can't participate in therapies, and then they don't get to go home if they can't pass therapy. Um, Hip dislocation. Let me just look at this. Okay, it's in the next slide, but we need to help them remember all of the protocols for having a hip done. Um, I'm going to look at my notes on the other page. Um, these people can't cross their legs, not even at the ankles. Um, so they have to keep their legs uncrossed at all times. If they are like unable to keep their legs apart, um, we can actually use an abductor or yeah, abductor pillow. It's just like a triangle wedge that goes in between their legs to make sure that their legs never ever cross. You can also use a pillow too, it doesn't matter. Um, but we want to make sure that they um, never bend more than 90 degrees. So like if they're sitting on a chair, we don't want them bending over and picking their purse up off the ground. Um, we want to make sure that they stay 90 degrees, so basically sitting up. Um, Skin breakdown. Um, Honestly, the skin breakdown that I saw from hip replacements was actually caused by the tape, and it didn't matter what kind of tape we used. But anytime they had a hip surgery, I swore every person broke out um, from the tape around the dressing, blistered actually. Um, Need to make sure that we're watching for an infection. They are given antibiotics prior to the first cut, and I think one more time in Broqua. Um, so we're giving them prophylactic antibiotics. We're teaching them cough and deep breathing. We're teaching them the incentive spirometry. You guys know um, those things from last week's material. Um, but we're also teaching them how to take care of that incision because it's a very large incision. It's probably 10 to 12 inches long. And staples, unless, well, they're changing now. They're moving more to glue. But in the hospital, they'll have their hip surgery. Generally, it's in the morning. Sometimes it just depends on how many cases there are that day. But they will come back to their hospital room. By that night, they'll be up and standing on their hip. The doctor comes the following morning, and the nurse has everything ready to go so that the doctor can just look at the incision. The doctor will be the one to take the dressing off. As a nurse, we never really take their first dressing off unless we are working with the doctor. The doctor has got to be the first one to take that dressing off so that we are in no ways rushing it or giving them another reason or risk for an infection. So, and then always we need to monitor how much they're bleeding. Um, if you have a dressing on a wound, you can actually monitor it by watching how much shadowing is on the dressing. You can look at the dressing and see if it's bleeding at all. Draw a line around it and write the date and the time. Come back maybe 2 hours later and just make sure that that circle or whatever the odd shape has not grown out past the circle that you drew. And then a lot of times these guys are going to have drains. Um, and we want to make sure that they are um, not draining too much into that drain. I think it's like 200 cc's an hour. It's some crazy high amount that seems really high to me, but all right. So, what are we going to do to prevent complications? We're going to walk. We're going to walk, walk, walk. So, um, physical therapy is actually the boss. They will come in and see the patient that night from surgery and have them march at bedside. They might go for a little walk, but more times than not, they're just going to march in place. And so that way, when they come back the following day, they're really, really, really going to work them hard. Um, Generally, physical therapy, The second day, I see them walk probably about 500 feet. And it's pretty amazing because it's weird to think, hey, they just had their bone cut and metal placed where their bone is supposed to be. Um, I have never seen them use crutches. I've only seen them use a walker when they are up walking after a total hip. Just because crutches are so much of a worry about them maybe falling and hurting that hip, maybe dislocating it easier. So it's just much easier. They just use a walker. We need to make sure that they're not getting blood clots. We're going to have the SCDs on them. Sometimes they will uh, fight you tooth and nail about wearing them, but we're going to teach them leg exercises. We're going to get them up walking as long as therapy says we can. And we're going to be giving them Lovenox. I don't know how long they go home, if they have a set time anymore, or if it's just until their INR reaches 2.0 and above. But anyways, in Viroqua, they go home with Lovenox for as much as they need until their INR gets um, to a good level where they're not worried about blood clots. Self-care. They will need to go to therapy, whether it's inpatient or um, outpatient. More often than not, it is outpatient. But they're going to need to go to therapy for quite a while. Get used to walking on that new hip. I'd raise toilet seat because we don't want them bending over at all. We don't want them to break the 90-degree rule. Um, and a lot of times they're going to have I don't know what they're actually called, but they help them put their socks on. They have a little grabber so they don't have to reach down and grab stuff. They can use their grabber bar and pick stuff up. So whatever assistive devices they can use to make sure that they are not breaking the hip protocols, um, it's amazing how far they've come. Like I said, they don't want them to cross their legs, so that's why they do the sock helper, so they don't have to put their ankle up on their knee to put their sock on. Um, all right, moving on to TKAs. I also saw it worked with a lot of these. Um, the total knee replacements, they basically peel back the um, kneecap sometimes, and they give a new kneecap. Um, and then they put a flatter piece. You can see here, the tibial part that's nailed into the tibia, um, and then the piece that's nailed up into the femur, and then the kneecap portion. With knee replacements, the dislocation is not a concern, and not unless they're doing some crazy yoga pose. Um, but with the knees, it isn't as scary as with the hips. Um, a lot of the care is the same for a hip as it is for a knee. Um, they will have what's called a CPM machine. Basically, keeps their knee moving while they're in bed while they sleep. Sometimes they will use it for the full 24 hours. Sometimes um, I think it has to be on for an hour every 4. It just kind of depends on how their surgery went and if they have any, the doctor's worried about any issues. Um, I know they're not really doing any bilateral knee replacements anymore. Those are terrible. I've seen several, and I've seen guys that I have known my entire life. It was actually a friend of mine's dad, who was a very tough guy. He was a construction worker, had both knees done, and was in so much pain because he couldn't um, walk and march in bed or march up to next to the bed and couldn't do the physical aspects of it. He basically just had so much more pain. It was so terrible. I ended up getting him like I think it was ketamine, to help with the pain. So just know that they're not doing double knee replacements anymore, just because the risks are so terrible with the double. They're going to be on Lovenox, the same. Um, Cough and deep breathing because they're not going to be as mobile. Yeah, so it's pretty much the same as a hip, except for they got the CPM machine. Um, they're not worried about dislocating it. And again, the dressing doesn't get changed till the following day. And the hips and the knees are now a 24-hour stay. They used to be a 72-hour stay, and that way they were covered if they needed to go to the nursing home. But now they have really, really amped down and are only doing 24-hour stays, unless there's issues, obviously. But generally, each person has a 24-hour stay. All right, amputations. There's surgical amputations and there are traumatic amputations. Surgical amputations are done anytime they might have a lot of, or I shouldn't say a lot of time. Very common, people who have peripheral vascular disease um, can actually have, their a below the knee amputation or above the knee amputation or even um, toes amputated, especially like diabetes. A lot of diabetics have their toes amputated because of issues, whether it's wounds, whether it's circulation, you name it. Um, Traumatic amputations are generally caused by accidents. I actually had students in on a case, oh, not too long ago. It was a farmer, and I honestly, it was for management, so I had a charge nurse and me were walking around, and a student was in ER. The patient had been out in the fields, and they had one of those manure spreading tubes, hoses, which are really big. Anyways, that got wrapped around this young man, and his friend was driving a tractor and didn't see him, and so when he was driving, pulling this hose, it just wrapped him up and pulled him into a like a culvert. I have never seen somebody so calm as I did that day. It was scary that he was so calm. He literally, I happened to be at the head of his bed when we transferred him. He was med flighted. When we transferred him, he just looked at me and says, "Can you make sure you tell everybody thank you for taking such good care of me?" Um, but his right leg was literally hanging on by about an inch. Um, and he could not, I don't know if he was in shock or he had gotten that much pain meds, but he literally could not feel it because all the nerves were damaged. Um, his right leg he ended up losing, and his left leg, I don't think they were able to save it um, because he had gotten compartment syndrome. They put the um, cast splint on, it wasn't a cast, it was a splint on there, and within 5 minutes, his leg was so swollen it was going up over the Velcro straps. It was a very sad story, and I, yeah, almost get tearful anytime I think about this poor guy. But he was pretty amazing. He was very, very calm, very sweet. Um, if you are out in the field and somebody has a traumatic amputation like that, where their limb is completely removed, um, you can put the body part in like a cold washcloth, and make sure that it's in a sealed bag, and then put the bag in water. And make sure it comes with the person to the hospital. It actually happens more often than you would think. Maybe it's just because I live down in rural area, but I know not too long ago there was an Amish young man who chopped off all the tips of his fingers. Um, So it happens more often than one would like to think. All right, this is our last slide. I made it. It's 2:30. All right. So for post-operative amputation care, obviously, as with anything, we're going to make sure that they are not hemorrhaging. Like I said, we're going to monitor their dressing. We're going to monitor any drains they have. Watch for shadowing on that dressing and watch for anything over 200 an hour out of those drains. Infection is a huge risk, especially if it was a traumatic amputation. Um, like this young man that I was talking about, he was in the fields where they were spreading manure. So you can about imagine um, how high of a risk for infection he had. Um, Pain control with amputation is terrible. Um, a lot of people have what's called phantom pain, um, and it's basically so if they have a below the knee amputation on the left side, they can literally feel their left foot, and it hurts. Their left foot is no longer there, but it can still hurt. It is a physically possible phenomenon. It's not just in their head, it is an actual physical symptom of amputation. It's terrible and it's very hard to control their pain, um, but it does happen. I have had some luck. I had a guy with phantom foot pain, and I brought in a mirror, like a longer mirror, and I would have him sit in his bed and put the mirror between his legs, and the his good leg would reflect in the mirror, so it would look like he would have um, both legs. And sometimes that would help. A lot of times they're given gabapentin because it's a nerve pain medication. It's also an anti-epileptic. But yeah, so if you ever take care of somebody with an amputation, please know that if they tell you their foot hurts and their foot is gone, their foot still really hurts. Not everybody has it, and it's not 100% of the time. It comes and it goes like anything else, but just know that it does happen and it's very hard to control. Mobility and ambulation, we just want to do whatever we can to prevent contractures. Um, Sometimes people feel better putting their stump up on a pillow, but if they do that too much, they can actually get a contracture in their knee, and their knee will stay bent. So we just need to help them move, do range of motion on the stump. Sometimes people get prosthesis, sometimes they don't. Just depends on what their wishes are. Sometimes they just stay in the wheelchairs. Um, but we just need to make sure we're doing what we can to make sure they're not contracting up. Talked about prosthesis. They can do wonders with prostheses now. Um, and yeah, anytime I see somebody with prosthesis, I think it's just amazing how they have adapted to walking on their own 2 feet to walking on one fake foot or two fake feet. Um, it's just amazing to me. Amputation is a total life changer. It's a total lifestyle. They have to adapt to everything, whether they're in a wheelchair, whether they're got some prosthesis and they're um, still able to do things, but it's a whole total lifestyle change. Anytime we have somebody that is going in for an amputation, they are a huge risk for mental health. I took care of a guy, oh, he was awesome, in the hospital, and he he was an old biker. I love old bikers, they're so much fun. Um, but he had a diabetic wound on his foot, and he would not um, accept that he had to have a bilateral or below the knee amputation on one side. Um, his biggest issue is that he wasn't going to be able to ride his motorcycle. So when we're taking care of these guys, their mental health is just as important as their physical health. Um, they're going to be grieving the loss of their limb, because to him losing, his leg meant that he couldn't do anything anymore. Yet he may not be able to ride a motorcycle, but I'm sure there's, and if you've ever talked about taking the bike away from a biker, you'll know what I'm talking about. But um, he was just grieving for his leg. It was terrible, and he ended up having the surgery. Had a lot of complications. Um, he was there for a long time, and I hadn't seen him for a while. And after he had recovered from all the complications from the surgery, he was like a totally different person. He's like, before before they took my leg, I was mad, I was pissed off, and I would cry every night because they were going to take my leg. After everything I've been through, I'm glad they took my leg, because if they wouldn't have taken my leg, I would have been dead. And that's exactly how he had to look at it to get past that grieving period. Um, it was just, I don't know, it's pretty sad to see, but pretty amazing once he realized the seriousness of it. And that, all right, well, that is all I have for musculoskeletal. Um, I was going to show you Picmonics. I might try and put some together, but I did call the Picmonic team tonight, and I did get everybody access to Picmonics for the rest of the semester. So I will be getting him out your address, your email addresses, your school email addresses, and try and get you guys set up as fast as I can. Hopefully, I can get it set up tomorrow. But Picmonic is an awesome learning tool, and I will let you know what I find out once I get all your addresses sent um, over to them. They said it doesn't take very long for them to get you guys all set up, so hopefully within the next day or two, you guys will have access to Picmonic. Um, Actually, I'm just going to show it to you real quick. I have one up. So, um, I don't know what I want to do. I had one picked out, and now I don't remember what I had. Osteomyelitis. We'll just do this. We're going to play Picmonic.
Use
Oh,
this Picmonic to help. Bones Jones sold his soul and is now a skeleton in flames. Chased by an evil band of bone-eating bacteria demons, he leaves behind a trail of warmth as he rides on his bike. But not a normal bike, no. He rides a chopper made out of edamame and wicked wheels made out of around-the-clock bone pain because now he lives for the pain of others. Wielding a fever beaver, he now terrorizes the poorest citizens of the city. However, he no longer wishes to live the evil life and seeks for someone who could put out his flames. Could ABX be that someone? You bet. So Bones visits him in his lab, where ABX guy immediately gets to work. He implants beads into his bones, leaving Bones unable to move. Then he throws him into a hyperbaric chamber with an oxygen mask, which puts out his flames. But that's not the end of it, no. Bones' little demonic minions come after him in ice ski mask disguises. However, that didn't fool ABX's surgeon, who was quick to slice the little guys up and perform experiments on them with ESR tubes. Later on, the hypothesis was confirmed that those bacteria guys were indeed evil.
so that's the little story.
Use this Picmonic to help you learn
I won't show you the whole
osteomyelitis
thing,
by
but
the skeleton in flames. Osteomyelitis is a bone infection shown by the bone with infectious bacteria. This severe infection affects the bone, bone marrow, and surrounding soft tissue, with the most common offending organism being Staphylococcus aureus. Clinical manifestations are both local and systemic. The infection site is often tender and warm to the touch.
okay, you guys get the idea. But I will get that out to him tomorrow to try and get, well, I guess today it is almost 3 o'clock. So that way you guys get access ASAP. It's a program, they're actually trying to get me to buy it, so that's how I got you guys to get free access for the rest of the semester. But it tells you a silly, stupid story to help you remember it. I used a lot of Picmonics on there. Um, and I might put something together if I can't get you guys access really soon. So, all right. Well, you guys let me know if you have any questions. I am going to set up a Zoom meeting. I was going to do it tomorrow, but then we were supposed to have a meeting, and then our meeting got canceled. So I will figure out what we can get so we can meet up with Zoom. And if you guys have any questions, please get a hold of me. Call me, text me, email me, whatever works for you guys. Okay. All right. Have a good one, guys.